Our next talk will be given by Mr. Claudio Ghetti, who is a third-year med student at the University of California, San Diego School of Medicine. And his paper is titled Evaluating Car Safety Compliance for Children Involved in Motor Vehicle Accidents, Identifying High-Risk Groups for Improper Restraint Usage.
Hi, everybody. Thanks so much for being here. Like he mentioned, my name is Claudio Ghetti, and I'm honored to be here today to present our Healthcare Disparities Project, which was evaluating car safety compliance for children involved in motor vehicle collisions. Our goal for this study was to try to identify some high-risk groups for improper restraint usage. I have no disclosures, and this work was supported by the Rady Children's Healthcare Disparities Research Grant. The reason that we're interested in this is, as a brief background, motor vehicle collisions continue to serve as a leading cause of death among children in the United States. And unfortunately, this disproportionately affects children from low socioeconomic status backgrounds, as well as minorities. There are a few proposed mechanisms for this disparity, including poor restraint usage, lower rates of car safety education, and barriers to timely and effective clinical care. The metric that we used in the study to quantify neighborhood socioeconomic disadvantage was the Area Deprivation Index. This is a metric that considers 17 census-based indicators of disadvantage, among which include educational, economic, housing, social, and transportation indicators. And the reason that we chose the ADI was it provides a much more granular look at the neighborhood level of disadvantage. I've included a ADI map of San Diego County in the bottom right for you to take a look at. And as you can see, there's a high level of heterogeneity even in San Diego. And so that's why it's important to look at the neighborhood level, and ADI allows us to do that. In recent years, ADI has been used in studies to analyze trends in pediatric trauma injury mechanisms within our California-Mexico border region, as well as grade pediatric burn severity. In our study, we took patients' home address, determined the ADI level, and then sorted it into quintiles. As I mentioned, our study was to evaluate the association between neighborhood socioeconomic disadvantage with improper restraint usage and subsequent clinical outcomes in children involved in motor vehicle collisions. Our hypothesis was that children from greater neighborhood disadvantage backgrounds would have higher rates of improper restraint usage and poor clinical outcomes. So this was a retrospective review of data from a level 1 pediatric trauma center. All of our patients were 18 years of age or less, and were evaluated in trauma activations following a motor vehicle collision between 2008 and 2018. Our primary outcome measure that we were interested, as I mentioned, was the improper restraint usage based on Area Deprivation Index. We also did a few subgroup analyses for children less than 8 years of age and greater than 8 years of age. And the reason that we chose this cutoff was that the California Highway Patrol sets this age cutoff as the age for being in a booster seat or not. We also looked at race and Hispanic versus non-Hispanic ethnicity. We were also interested in clinical outcomes data by Area Deprivation Index as our secondary outcome measure. Overall, 1,152 patients met inclusion criteria. 50% were male with a median age of 7 years, and 53% were Hispanic. The highest rate of improper restraint usage was seen in the most disadvantaged ADI quintile at 21%, and Hispanic ethnicity was also greater in this most disadvantaged ADI quintile, accounting for 73% of that cohort. In our subgroup analysis, we found young Hispanic children less than 8 years old were significantly less likely to be properly restrained in a booster seat compared to non-Hispanic children. And for our clinical outcomes data, we did not observe any significant differences by ADI. This is a table highlighting the ADI breakdown by patient ethnicity. Starting at the top, quintile 1 is the least disadvantaged quintile, and at the bottom, quintile 5 is the most disadvantaged quintile. The first thing I'd like to bring your attention to is the fact that quintiles 2 through 5 are relatively evenly distributed, but we did note a significantly smaller sample size in the least disadvantaged quintile 1. Furthermore, I think it's important to highlight that Hispanic patients made up a majority of the most disadvantaged quintiles, quintiles 4 and 5. This graph is a trend in improper restraint use by ADI. If we start at the left, quintile 1, the lowest disadvantage, quintile 5 at the right, highest disadvantage. As you can see, there's a clear trend in increasing improper restraint usage from quintile 2 through 5, although we did note that the second highest rate of improper restraint use was in quintile 1. And this may be in part be due to the fact that we had a smaller sample size in that cohort at only 11%. Overall, we found, as I mentioned, that children in the neighborhoods with the greatest socioeconomic disadvantage and younger Hispanic children were less likely to be properly restrained in the car. We also found that probably more importantly, the big takeaway from our study, if we take a step back, is that this Area Deprivation Index tool really allows us to look at the neighborhood level, which is different from a lot of other socioeconomic indicators. And as I'll mention in our other conclusion slide, this can be extrapolated to the rest of the United States in regions that have different patient populations from our own. And the future direction of our study is to use this data to supplement current car safety education and injury prevention programs right here in San Diego in high-risk neighborhoods. The limitations of our study was that it was a retrospective single institution study, and as I mentioned, our results may differ from other areas of the country. With regards to our clinical outcomes data, it's possible that a larger study population might be necessary to observe significant differences, but we're optimistic that ADI can be applied in future trauma research studies around the United States, and we encourage that as well. Thank you so much to Rady Children's Hospital and the folks at Scripps Mercy and UC San Diego for their work on the project, and I'm happy to take any questions.
Okay, this paper is open for discussion.
So Catherine Martin from Westchester Medical Center. I'm just wondering if you have any sense of the education that these families would be provided and ideas of how you might change it or research or interventions you might do and appropriate formats for that.
Definitely. So there are a couple key organizations here on the ground in San Diego, one of which is Safe Kids San Diego, who work specifically in this area. But things like educating on proper booster seat usage and even access to booster seats is really important. So that's the future direction that we're planning on taking as the next phase of our study. Thank you for that question.
Upperman Vanderbilt, a very nice presentation. We actually found in Los Angeles County back in 2016 that we all were kind of silly and didn't understand how to restrain people. And it was pretty ubiquitous. We only had like 3% of families who were seen at car seat events and the like across the county actually had their children or the car seats restrained appropriately. So I think the educational question was raised earlier may be not necessarily split in an SDI way, but it may be across the board because the book is this thick. I mean, I didn't know what I was doing when I took all three of them away. You know, I finally figured it out, but it's not as straightforward as some may assume it is. Nice work.
Definitely. Yeah, that's a great point. And I think it's also important to recognize that the definition of proper restraint use varies across state lines and even county lines. And so it is applicable to all of the quintiles of area deprivation index because it can be confusing. So thank you for that question.
Dr. Gaines.
Barb Gaines from Pittsburgh. I actually think one of your limitations that you stated is actually the strength of your study is that you looked at your local community using your local data so that you can figure out what your local intervention is going to be. I think sometimes when we generalize to everyone it looks like this, then we don't find the solution for what's right next to us. And so I commend you for looking at your data so that you can understand your community better so that you can target an intervention that works for your particular community.
Thank you. I appreciate that feedback very much. And that's exactly why I think this is such an important tool that we can extrapolate to the rest of the United States.
Max Langham. I'd like to follow up on Dr. Upperman's comment a little bit. As a grandpa, I struggle with getting my car seats involved correctly. I would hypothesize that the lowest socioeconomic group that you have drives older cars that have less airbags, that are lighter, and that have poorer maintenance, and therefore may have a greater incidence of injury if an accident occurs. And your index for an exposure was an injury presentation to a trauma area. If my modern Volvo, if I don't have the car seat installed quite right and the airbags go off, it's highly likely one of my grandkids will not be seriously injured compared with a 1975 vintage Ford Pinto. So I was wondering whether or not you might re-look at your data and see whether or not you have any information about the automobiles, or if there is another way, like Dr. Upperman did, of looking at proper installation of car seats and look across the broad population to see if there really is a difference?
Yeah, thank you for that question. We didn't have access to that data, but that is a good point to make. Although we did notice that, as I mentioned, the quintiles 2 through 5, the higher you go, 4 and 5 are the most disadvantaged. Those are relatively evenly distributed. So in terms of presentations to the trauma center, whether they were driving older cars or not, those quintiles were relatively equal in terms of total trauma activations. But that is something that could be done in a future study for sure.
How would you envision designing an intervention to fix this problem? I'm thinking, kind of what Dr. Upperman was saying, that when I had my first kid, we took the car up to a safety stop area at St. Louis Children's Hospital, and they checked to make sure the car seat was properly installed. And that's a very easy access point. Before your child leaves the hospital, you make sure the car seat's properly installed. As your child gets older and they transition to different types of car seats and then booster seats, there aren't as many people there to check along the way or make sure you're doing it right. So it seems like in my mind, maybe the best way would be at the pediatrician's office for them to kind of check on that, as part of their routine. But I was wondering if you had other thoughts or how you could involve the community there.
Yeah, that's a great point, and thanks for bringing that up. One of the other issues is the access, right? And you mentioned it, as kids age, the patients from the more disadvantaged backgrounds don't necessarily have the means to buy increasingly larger booster seats. And so at the specific neighborhood level, I think, as I mentioned, the boots on the ground, so to speak, Safe Kids San Diego is an organization that we might look into in terms of educating with our results and providing them with that data so that they can figure out which pockets to specifically target for these checkpoints.
And last question, obviously prevention is the best strategy, but once you get these patients that come in accidents and you find that they're improperly restrained, what interventions do you have at that point to prevent a recurrence or maybe a problem with another child in the family?
Yeah, so that can happen at the physician level, assuming that the physician knows when they come in, was this child properly restrained or not. It can be incorporated as part of the visit, even just mentioning it like, would you like resources for information about proper restraint use for future occurrences and things like that.
Thank you.